So welcome, and please feel free to ask any questions if anything's not clear. As Dr. Rothstein said, I'm a clinician. I look after patients whose lungs have failed and are on ventilators, but I'm also a researcher trying to develop new treatments for that disease. As concrete evidence of my interest in bringing treatments from the bench to the bedside, our work has led to a couple of patents, and I'm disclosing that to you now. So the lungs are a marvel of design or engineering or whatever you want to say, in that they're optimized to allow very rapid absorption of oxygen and very rapid clearance of carbon dioxide, of waste. And I'm sure you've all learned that in your biology classes. And the most important, or the most hardest working part of the lung is this functional unit here, the air sac or the alveolus. And the alveoli, you may not know this, are incredibly delicate because they're optimized for what, as I said, for absorbing, allowing oxygen to be absorbed into the blood and allowing carbon dioxide, the waste in the blood, to be ventilated out. So in the alveoli, there is a single layer of lung epithelial cells, and this is the air sac. This is where air comes in. This is where, if you would have the misfortune of inhaling a virus, the virus would come in. And next to this single layer of air sac cells, of epithelial cells, is the blood vessel that picks up the oxygen and discharges the carbon dioxide. What this means, if you think about it, is there are two layers of cells standing between your blood circulation and the air in your lungs. So in other words, two layers of cells preventing you from drowning should this barrier get broken. And it's a particularly nasty kind of drowning. I mean, not that there's a good way of drowning, but it's a particularly nasty way of kind of drowning, because if this barrier breaks, the plasma or the fluid that makes up your blood will go into your air sacs, and you'll basically drown from the inside out. And that's the title of the talk. And this is not, unfortunately, a fantasy or something from a horror movie. It's real. There's a name for this disease. It's called the Acute Respiratory Distress Syndrome. It's also called Acute Lung Injury, ARDS or ALI. And this is an X-ray of a patient who had this. I got this X-ray when I was in residency training. And you all know, or you may all know, I guess people don't use film anymore, but this is an X-ray, and you know that air doesn't block X-ray beams, and that's why in normal X-rays the lungs would be black, because the X-ray goes right through the lungs and makes the film black. And you can see that in this patient, actually, these lungs aren't black, they're white. And they're white because the patient's lungs, those alveoli, are full of plasma, of fluid. This patient is drowning from the inside out, from ARDS. And this is a devastating disease. It's one of the most common diagnoses that I look after in the intensive care unit across the street. And it may shock you to know that we have no treatments for this, that in 2019, there's no magic bullet for this. The mortality rate approaches 40 or 50%. And really the treatment is what we call, in quotation marks, supportive care, which is I try to keep you alive so that your body heals itself. You know, if you have an infection, I'll give antibiotics. I'll try to find the underlying cause of the leaky blood vessels, but I don't have anything that can stop those blood vessels from leaking. So what causes this disease? I've alluded to the idea that your lungs are incredibly delicate. The alveoli have those thin layers of cells, and that it's the breakdown in that layer of cells that allows the fluid in the blood to flood the lungs. And this is a picture of that, a close-up, showing again this air sac lined by a single layer of cells and this blood vessel, this capillary next to it. And the formation of holes in this layer is what's allowing fluid to leak out into the lungs. Now, from the X-ray that I showed you just now, it may look like the entire lung is flooded with fluid. It doesn't really look like there's a lot of normal lung there. But we now know, because of CAT scans, our ability to take X-rays not just from this way, but also to take an entire picture of the lung and look at it in slices, that actually it's not all of the lung that's involved. So here on your left is a normal lung. You can see the lungs are filled with air. And what you're doing is you're looking at instead of looking face on at the patient, you're actually looking at a cross section. And this is a patient with ARDS. And you can appreciate right away that this image on the right looks very different from this image on the left. there's this area of the lung that's white, full with fluid, and you can imagine there's not a lot of good gas exchange happening there because that part of the lung is flooded. And on the other hand, this part of the lung looks relatively normal. So this disease, even though on an X-ray looks diffuse and it looks like it involves the entire lung, is actually very heterogeneous. There are areas of the lung that are relatively spared and areas that are devastated. And this makes treating ARDS very, very difficult. And here's why. So as I told you, the standard of care for this disease is to keep the patient alive until the body heals itself. And one of the ways that we keep the patient alive is we breathe for them. We put a breathing tube in, we hook them up to a ventilator that blows air into the patient and takes over their breathing. You can imagine that in a lung that looks like this, if I breathe for the patient, all the air is going to go here. And it's not going to go here because this part of the lung is completely waterlogged. Think of a wet sponge, okay? And because of that, when I blow air into the patient, it inflates the normal regions of the lung. It over-distends them. Just think of what happens if you keep blowing into a balloon too much. And it can also actually cause lung damage. So mechanical ventilation of the injured lung is very, very difficult. If I give medication by inhalation, let's say, okay, the patient's on the ventilator, I'm going to give them an antibiotic or a medication through the tube. Again, you can imagine easily that that medication I give the patient will go to the normal part of the lung. It's not going to go to the diseased part of the lung that is waterlogged like a sponge, right? Because the air is going to go in and it's going to go to the path of least resistance, which is the normal part of the lung. I don't need to treat the normal part of the lung. I need to cure that waterlogged part. And if I give a medication by intravenous injection or through the stomach, I'm going to have that medication circulating through the blood. It's going to affect other organs, not just the lung. And if it goes to the lung, it's going to go to the areas of the lung that are relatively normal. And I don't need to treat the normal part of the lung. So you can see where I'm going. This is a very difficult disease to treat, and part of it is because we can't target the injured lung regions. So one of the innovations my lab is working on is the notion that we can precisely target the injured lung taking advantage of ultrasound. So I don't know whether you guys have learned in physics class about ultrasound energy, but this is the same ultrasound. These are the same ultrasound machines, ultrasound devices, and ultrasound principles that are used to take pictures of babies in pregnant women, or to take echocardiograms of the heart. And the realization I had in collaboration with Rafi Karshafian at Ryerson University and at iBest a few years ago was that ultrasound waves do not penetrate air. So I don't know if you've ever seen if pregnant women have an ultrasound of the baby, but the first thing they do is they slab gel all over the skin, this goop. And that's because the ultrasound waves don't penetrate air. Air scatters ultrasound. You need the gel to get rid of the air. So we had the idea that we could take advantage of that fact, because if you apply an ultrasound wave to the lung, it will only penetrate the injured lung. It will not penetrate normal lung that's filled with air. You see what I'm getting at? So this is a way of targeting the injured lung. And we also took advantage of another piece of knowledge, which was that there are these tiny bubbles, 1 to 5 micrometers in size. So this is 1/1,000,000th of a centimeter in size. That's how small it is. And inside this bubble, there's a gas. The outside is a lipid. And these are actually routinely used in medical imaging to help visualize the heart. So they're safe. They're used to image the heart. And it's known that when ultrasound waves meet these bubbles, when ultrasound waves and these bubbles interact, the bubbles sort of oscillate. They go smaller and larger. And this oscillation and even the popping of the bubbles stimulates the cells around to increase their internalization or their uptake of drug. So if you imagine this is a blood vessel, I've injected microbubbles into the blood, I've injected a drug at the same time. If this microbubble encounters an ultrasound wave, there will be enhanced delivery of the drug in that area. Now, I've already told you that the ultrasound wave will only penetrate the injured lung because normal lung scatters ultrasound. So what that means is, if ultrasound only penetrates injured lung, and if ultrasound, when it encounters the bubbles, causes increased delivery of drug, I will have increased delivery of drug just in the injured lung. In the normal lung, I won't, because the ultrasound wave doesn't even get there. So what I'm proposing is that we could use ultrasound as a means of delivering drug or genes or antiviral drugs specifically to the part of the lung that is injured and spare other organs and spare the normal lung. So to test whether this hypothesis is correct, we developed a model of pneumonia. One of the commonest causes of that lung injury where you flood from the inside out is just run-of-the-mill pneumonia. So in this model, mice get bacterial pneumonia, and the lung, instead of looking nice like this, where there's all these air pockets, the lung is completely bogged down with white cells and pus. And this model is associated with the mice having low oxygen, as you might expect. And on this graph, what we're seeing is a measure of lung edema. The mice that get the bacteria, called E. coli, have more lung edema. So this is a good model for ARDS and allows us to test our hypothesis. We wanted to make sure that it was safe to do this, so we measured the oxygen level in these mice. And what we did is we had two groups of mice. One group of mice got the ultrasound, US, and microbubbles. One group of mice did not get them, so that's the control group. And we measured the oxygen levels just to make sure that applying ultrasound to this injured lung doesn't make it worse. And all I'm showing you here is that oxygen levels in both groups are basically the same. And if you look at the lung under the microscope, it's basically the same. So the technique of applying ultrasound and microbubbles is not hurting the animals. Okay. But the specific question is, does it help them? So there's some data there's a lot of data in intensive care unit patients that microbubbles are safe, if they're not going to hurt them. So we felt confident that it was safe in the mice. There's clinical data in humans that it's safe, so we decided we would test our hypothesis and try to treat pneumonia in the mice using this approach. This is just to show you a study where it reports that pneumonia is the commonest cause of acute respiratory distress syndrome. And the approach we decided to take was to use an antibiotic that would be useful in pneumonia but is not recommended. So these are guidelines that physicians read about which antibiotics they should use. And it says here that this is listing which bugs, which germs are causing pneumonia, and a lot of them are gram-negative, so-called gram-negative bacteria. And we have a big problem in the intensive care unit in that many gram-negative bacteria are antibiotic resistant. So can you imagine having an infection in your lung, and you think, well, why don't they just give me antibiotics? But they can't, because the bacteria in your lung is resistant to all antibiotics. So as it turns out, this is a growing problem. Bacteria are resistant to antibiotics, but all of them remain susceptible to a class of antibiotics known as aminoglycosides. These are antibiotics that's with the name streptomycin, kanamycin, basically that class. And this class of antibiotics is actually not recommended in pneumonia because it doesn't go to the lung. So if you have pneumonia and I give you that class of antibiotics, that antibiotic doesn't go to the lung. It's not useful. And in fact, even if I give you the recommended dose, it can cause damage to your kidneys and damage to your inner ear. So I thought this is a perfect opportunity to test our hypothesis. Maybe we can deliver a low dose of antibiotic to these infected animals, use our ultrasound device and technique to enhance delivery of that low dose of antibiotic to the lung, and specifically to the injured lung. And at that low dose, there'll be no damage to the kidney, no damage to the inner ear. It's basically a type of targeted drug delivery. So in other words, can we use ultrasound to increase the efficacy of these antibiotics, reduce the dose that we're administering, and because of that, reduce the risk of toxic effects to other organs? So this is a cartoon showing the notion of our theory. So you have the lung units, those alveoli air sacs that are filled with fluid. They allow ultrasound waves to penetrate. We have these microbubbles and our antibiotic that are circulating in those blood vessels next to the air sacs. In the injured lung, ultrasound waves encounter these microbubbles and cause increased antibiotic delivery in the lung, in the injured lung. And of course, if there's more antibiotic delivery here, then there's less antibiotic in the rest of the body to injure the kidneys, to injure the ear, or to be delivered to the normal lung. So this is the model, same model as before, where these mice get infected with a bacteria named E. coli. They get a very low dose of antibiotic. They get the microbubbles. They get the ultrasound. And to test our hypothesis whether this idea works, we measure the killing of bacteria, the number of bacterial colonies in the lung, and we can actually measure the antibiotic levels themselves in the injured lung. This is a bit of a complicated graph, but I'll take you through it. On this axis, we're actually counting the number of bacteria in the lung. And this is a log scale, meaning that this is 10-fold greater than that, and this is 100-fold greater than that. And then these are all the different conditions that we tested. The important point is here in the hatched box. This is this condition where the mice got antibiotics, they got microbubbles, and they got ultrasound. You can see had the lowest number of bacteria. And this is a 10-fold reduction in bacteria in the lung. So think about what I'm telling you. I'm giving a dose of antibiotic that's not toxic, that's not effective because it doesn't go to the lung. All I'm doing is I'm applying ultrasound to the injured lung, injecting microbubbles that are FDA, Health Canada approved, and I get an increase in bacterial killing by 10 times. And these are all the different permutations showing that you need all three things, the antibiotic, the microbubble, and the ultrasound. And then if you actually take these animals and you measure the antibiotic delivery, we can show that in the lung tissue, there's a 2 to 3-fold increase in antibiotic delivery. And if you wash out the lungs and measure the antibiotic in the air sacs themselves, we see the same thing. Now, these experiments may seem relatively simple, but they prove, I think, an interesting idea that ultrasound and microbubbles can be used not just to deliver antibiotics, but maybe anti-flu drugs, maybe in the future gene therapy. And basically the idea that we can now target the worst part of the lung and spare the best part. Because if you imagine, this technique would work best if the lung is the most injured, because it will allow the most ultrasound penetration. So my lab is actively working to see whether we can expand on this pilot work, on this preliminary work, to deliver even more exciting payloads to the injured lung. And by payload, I mean things like gene therapy. Can we actually not just kill bacteria, but can we actually heal the injured lung from the inside out, prevent blood vessels from leaking, and do what I would call a form of precision medicine, where we treat the most injured part of the lung and spare the rest of the body and the normal lung. So that's one of the projects in my lab for which we have a patent application. The second project I want to finish with has to do with, do you remember Dr. Rothstein talked about how I work a lot with cells? And so what causes ARDS is the blood vessels in the lung become leaky. And you may not know that every blood vessel in the body has a lining. And that lining is called the endothelium. And it's shown in this cartoon as these blue rectangles. This is a cartoon of a blood vessel seen from the side. So this is like the blood. And these blue rectangles represent that lining called the endothelium. And one of the functions of that endothelium is to prevent your blood vessels from leaking, preventing you from drowning, if you want to put it that way. And it's known that when you get really sick, or even not so sick, I don't know if anyone here has ever sprained an ankle or broken a bone, but you probably know that you get swelling. And part of that is because your blood vessels leak. Now, I look after the most severe cases of that where the flooding occurs in the lung or the flooding lowers your blood pressure. But the principle is the same. These lining cells are held together by cell-cell junctions. The name's not important, but these junctions are made up of specific proteins that hook the cells together. Okay? And you can easily imagine that if these cell-cell junctions break or get destroyed in some way, you'll end up with gaps between the endothelial cells. You'll end up with holes. You can just think of the garden hose you have at home. If there are holes, little tiny holes in the lining, you'll end up with vascular leakage. The other way that endothelial cells can leak is the scaffolding, the internal corset that holds them together can change shape and cause the cells to shrink. And when that happens, when cells start to shrink, you get holes forming in the layer and you get leakage. And so my lab is trying to figure out at the molecule level how to prevent that gap formation from occurring. So this is a microscope view of the same thing. You see these tiny flat cells. These are the endothelial cells. And if in addition to gaps forming between cells, if the cells themselves just die, you'll also get leakage of the blood vessel. So one of the aspects that we're working on is our family of proteins known as angiopoietins. The name's not important, but but what's interesting is that endothelial cells have a receptor on them called the Tie2 receptor. And if you stimulate that receptor on endothelial cells, you might be able to prevent those gaps from forming between cells. And you might be able to prevent the endothelial lining cells from dying. In other words, you might be able to prevent blood vessels from leaking. So colleagues of mine, collaborators of mine at Sunnybrook Hospital invented a drug that binds to this Tie2 receptor. They called this drug vasculitide. It's completely new. Nothing like this exists in nature. And they allowed me to test it using our model of lung injury. And so basically the hypothesis was, if in a mouse model of severe lung injury, where the lungs are leaky because of influenza, for example, a flu, if I give this drug, can I rescue the mice? Can I improve survival by decreasing lung injury? And so we published a paper on this, and I will show you some of the data because it's very exciting. So it turns out that mice are susceptible to human influenza. And in fact, this is a model where if you infect mice with influenza, human influenza, all of them die within about a week. This is a very scary infection. It's sort of, if you think about it, similar to those scary stories you read in the news about pandemic flu or an avian flu strain coming. So that's sort of what we're modeling. And if we give them this drug vasculitide, which is abbreviated here VT, you can see that instead of a survival rate of 0, we can improve the survival to about 75 to 80%. And what these combinations are showing, VT0, VT24, these are basically variations on when we start giving the drug. Okay, so if I give this drug vasculitide at the time of infection, I get about an 80% survival rate. That sounds great. But if you think about it, think from a practical standpoint, most of us don't know when my classmate coughed on me and gave me the flu, and so I'm not going to start taking my drugs. So that's nice for research, but for real life, you need something that still works 3 days after Jimmy coughed on you, right? So we tried that, and so if we administer the drug 24 hours after the flu, we still have improved survival. In fact, as long as 3 days after the flu infection, this drug can save the mice, which is kind of cool. And what I'm showing you again, this is on this graph, I'm showing you the oxygen saturation of these mice. The black dots show mice that got the flu, and you can see they're getting low oxygen because their lungs are flooding with fluid. This group in red gets the drug vasculitide, but they get it starting at 3 days, 72 hours after infection, right here. And look what happens. Oxygen saturation starts to improve. So we're basically rescuing the mice using a new drug that targets the lung lining fluid cells, the lung lining cells, the endothelium. And it also improves other things like body temperature and weight loss and so on. We were able to show that this approach works not just against one strain of flu, but against 3 different strains of human flu. And one of the things that's really cool about this approach is that we're improving survival by making the animal stronger. We're not developing a drug that tries to restrict the virus from replicating. So let me explain that better. The virus, if you administer an antiviral drug to cells or to animals or to humans that have flu, the virus will mutate. It will adapt. It will become resistant, right? That's the process of natural selection that you hear. This drug, this approach, has no effect on the virus. The virus doesn't know it's there, right? All I'm doing is making the human, the animal, the cells, I'm making them stronger. There's no selection pressure on the virus. So I should not encourage the development of viral resistance. So this is what we call modulating the host response, improving the host response. So as I mentioned, this works against the second flu strain. It even worked against the 2009 pandemic swine flu strain. So it doesn't matter which strain of flu, this approach holds promise. And it also, if you think about it, would hold promise for other infections of the lung that cause lung leakage. We are actively doing research to try to find out the specific way, at the very specific molecule way, how this drug is working. And we believe that it's working by preventing the lung endothelial cells from dying. Because as I showed you, if every blood vessel in your body has that sheath of endothelial cells and you get holes in that sheath, it's easy to see how you can get cell death and blood vessel leakage. So one of the ways that these cells die is through a type of programmed cell death that you may or may not have been exposed to yet called apoptosis. And so when we monitor apoptosis by measuring the formation of a specific enzyme called cleaved caspase 3, we can show that our drug vasculitide is causing less apoptosis to occur in cells that are infected with flu. So I hope I've given you a taste of some of the exciting work that's happening here. And I hope that this will nurture some of you to want to go into science and medicine, because this is a really exciting time to be doing both. ARDS was first described in 1967, so over 50 years ago. And there are no specific treatments for it yet, believe it or not, right? The treatment is keep you alive until your body heals itself. My hope is that with the work that we're doing here, we're going to be able to change that. First, by understanding what's causing ARDS, and then, of course, by developing specific therapies to target the injured lung. These will include blocking leakage of those endothelial cells that line every blood vessel using the Tie2 agonists, or developing a way to deliver drugs and genes of our choice to specific regions of the injured lung in a form of precision medicine. At the end, I'd like to highlight the fact that this is a team effort. This is a very collaborative approach, and if you like working with other people, science is the place for you, because this is not something I can do by myself in my garage. Much of the work that I've presented has been done by a former PhD student of mine, Michael Sugiyama, and a current master's student of mine, Victoria Minsopoulos, along with many collaborators and with the generous support of granting agencies and foundations. So I would be happy to take any questions if there are any.